Hello and welcome to the second Hypothyroid Hangout series. On behalf of RLC Labs, I'd like to welcome our viewers to the second Hypothyroid Hangout. My name is Nora, and today our speaker is Dr. David Klein of Stages of Life Medical Institute in Longwood, Florida. Welcome, Dr. Klein, and thank you for joining us today.
Well, pleased to be here. Thank you.
Before we begin, I would just like to remind everyone to please read the disclaimer information that is provided, and please note that this Hangout is not intended to replace a patient-physician relationship, and any concerns that you have should be directed to your physician. So a little bit about our speaker today, Dr. Klein. Dr. Klein is the founder and director of Stages of Life Medical Institute, and he is a graduate of the University of Maryland School of Medicine, and he's also currently an associate professor at the University of Central Florida School of Medicine. His concentrations are in treating neuro-endocrinological problems, enthesopathic pain, and he practices functional-integrative medicine. Today, Dr. Klein will be speaking about combined therapy, adrenal and thyroid access, specifically what combined therapy is, what the advantages of combined therapy are, and what the risks are in not treating the thyroid in this manner. Take it away, Dr. Klein.
Okay, well, thank you very much for being here this evening. This is a topic that's very near and dear to my heart. Okay, having issues myself with thyroid and having to treat myself for it. In any event, the way I'm going to start this is by making a statement more than anything else. Typically what I do this in front of an audience, I'll ask the following question, which is 1, what is a hormone? 2, what does it do? And 3, how does it work? Well, given the fact that I can't get anybody to stand up and answer the question given this format, I'll answer the questions myself. A hormone is not just simply a chemical. Okay, it's nothing magical. It's a moiety. It's a chemical structure that triggers actions remotely from the source of origin. Now, endocrine function implies that every cell in the system speaks to all other cells. Unlike the wired system in a telephone, this is more the wireless system. So a fat cell can communicate with the thyroid can communicate with your eardrum. Okay, and it goes around and around and around. And this is very, very important. How does a hormone work? Okay, a hormone works by triggering a genetic change. Now, that doesn't mean changing a gene. It means firing it or shutting it down, turning it on or turning it off. And this is something that happens very, very quickly. Fundamentally, all cells in the body, except for red cells and your gonads, have identical genetic material. Okay, so then why is it the cell in your skin is different from the heart muscle? All right, it has to do with the way the genes in that structure, that cell, are firing. And you can turn them on and you can turn them off with hormones. So that is what they are, how they work, and why are they important. Because again, communication within the structure is terribly, terribly important. What happens in the pancreas and what happens in the gastrointestinal tract communicates largely by the endocrine system. Okay, so thyroid, okay, is only one of many, many endocrine issues. It's only one gland amongst many. It's not the most important. They're all important. The most important gland that you have, the most important hormone at missing, or the one that's out of whack. Okay, now, so let's start with thyroid because that's really the focus of the discussion here. Thyroid hormone is actually 2 separate hormones. It starts off as T4 secreted by the thyroid. It's converted largely in the periphery to something called T3. Now this is important because T4, sometimes known as Synthroid, Levoxyl, some of these others, is actually what's called a prohormone. Okay, it doesn't actually work. It has to be converted T3 to structure, to work at all. So when you give just T4 alone, you're assuming that the body will convert it properly, adequately, and efficiently to T3. But such is not typically the case. Okay, the enzyme that's responsible to make that conversion has a name. It's called 3,3,5' deiodinase. Okay, that enzyme has 3 morphologies, each of which is triggered genetically. 2 of them cause the formation of something called reverse T3, and only one of them effectively gives you a regular T3. So the reason for this is it gives your body the ability to lower the thermostat or raise the thermostat, as the case may be. Now, so what does the thyroid do? It sets and maintains metabolic rate. It raises and lowers the temperature. If I were to ask, what's a normal temperature? The answer is almost always the same. Oh, it's 98.6. It's not. It's never 98.6, but for 2 times a day. Half of the time is spent above that, half of the time below. It gets to no lower than 97.6 and no higher than 99.6. It fluctuates between 4 a.m. and 10 p.m. in this manner. This is done largely by thyroid function. So your body is maintaining and monitoring this on a constant basis. So that's what thyroid does. Where does thyroid hormone work? Most hormones work at the level of the gene. So the thyroid hormone sits around in the bloodstream, makes its way through the cell membrane, gets transferred to the nucleus, passes through the nuclear membrane before it approaches the genetic material. Okay, those are many active processes, any one of which can break. So when you go ahead and you check people for thyroid hormone levels, any one of these areas can cause errors to occur. So when somebody comes in and goes, oh, gee, they tested my thyroid hormone and it was normal, but I feel like just awful. My temperature's 96 and change. I can't this. I gain weight, heavy irregular menstruation, headaches, bitemporal headaches, depression, sleep disorder, yada, yada, yada. You know, say this looks like hypothyroidism, but my doctor tells me it isn't. Well, the doctor's an idiot, and here's why. Because the fundamental measurement that rarely ever gets taken is called temperature. So how often do you go to the doctor's office and they don't even bother taking your temperature? They'll tell you that it's normal. Well, what's normal? As the day goes on. So in my practice, and I've been doing this 35 years, we record the time of day the temperature is taken. Because a temperature of 97.6 at 8 o'clock in the morning is fairly close to normal. At 4 p.m., it's 2 degrees cold. Okay, so you have to take the temperature in context of time of day. Very simple, very straightforward. So what does the thyroid do? The thyroid sets and maintains metabolic rate. Now, how do these hormones actually operate? Well, they don't operate one hormone, one receptor, one effect. It's really more like the tumblers in a combination lock. There may be 3, there may be 5, there may be 30 hormones that have to be within balance in order to trigger a gene, which is why when a girl's progesterone goes up, her breasts may enlarge, but her eyeballs do not. Okay, you can give somebody estrogen, of which there are 3 main estrogens, and they're all different, and they have different effects on different tissues. Okay, this is fundamental. Okay, so what happens? Well, if it takes 3 properly balanced hormones to affect a proper thyroid trigger, and any one of them's off, guess what? The lock doesn't open. The gene doesn't fire. The enzyme, which may be caused by that gene to fire, doesn't get produced. So what you find in this business is that folks that have low estrogen levels end up with low TSH, even if they're profoundly hypothyroid. So when you go ahead and you test somebody for thyroid function and you don't check their estrogen levels, that's men and women, you find that you miss it about every time. What else? Testosterone. What else? Progesterone. What else? DHEA. What else? Androstenedione. What else? DHEA. Pregnenolone. What else? Parathormone. Okay? All are necessary assays in order to determine what's wrong. So the thyroid and the adrenal glands and these other hormones largely come from the adrenals. Okay? If they're not in balance, nothing works. If you can't assay this thing properly, you will never establish a proper diagnosis. So what happens with the thyroid, okay, is it tends to be attacked first. It's the thing that burns down first. The thyroid is a very superficial gland. It can be damaged by trauma. It can be damaged by infection. It can be damaged by neoplasm. It can be damaged more commonly by autoimmune disorders. Okay, 1/3 of the patients floating around out there with thyroid disease, those that are diagnosed and those that are undiagnosed, are autoimmune in nature. How do you diagnose autoimmune thyroid disease? Not with a TSH. Not at all. You do something called a TPA, or thyroid peroxidase antibody, and antithyroglobulins. If you do not look at these assays, you will miss the diagnosis every time. And these are the people that come in with the following complaint. I feel this, I feel that. It all started off with mono. They told me I had EBV. They told me I had Lyme's disease. Then I had nodules on my thyroid. And then, God help you, they rip it out surgically or with radioactive iodine. And now you're done. It's over. Okay, why? Because it doesn't grow back. But you're still hypothyroid. Why do you suppose that is? Because autoimmune thyroid disease hits other tissues as well, to include the adrenals, to include the parathyroid glands. So you may burn somebody's thyroid out, you leave the parathyroids. So routinely I do parathormone levels. The joke is that folks with autoimmune thyroid disease almost always have elevated parathormone levels. Very, very interesting, but it's essential to make the diagnosis properly. So, so what have we got here? Okay, we have thyroid, we have thyroid production, we have thyroid destruction. So how do we make the diagnosis of hypothyroidism far more common than hyperthyroidism? Hypothyroidism, 9.5 times out of 10. Hyperthyroidism, very rare. Now, when you have autoimmune disease like Hashimoto's, like lupus, like MS, like the list can just fly on. Sjogren's, it doesn't really matter. Autoimmune thyroid is extremely common. Okay, it just happens. It's going to happen. It will happen. So you need to be in there getting CRPs to follow this, but you really do need to look at the entire picture. So when you're doing an endocrine evaluation, you can't focus on one gland, one complaint. Now, that being said, if you sit back with your wonderful WebMD internet and start looking up your symptoms, you're going to say, oh, gee, there's my picture. I am the poster child on WebMD for thyroid. Get a look over at adrenals. There's your picture, because they're all the same symptoms. They're all the same. Why are they all the same? It gets back to the combination lock. So if the combination lock closes because of too much or too little of an essential element, an essential hormone, essential chemical, everything breaks down. That's why you gain weight. That's the depression, the bilateral temporal headache, which is inevitable, comes from a pinching nerves, bilateral carpal tunnel, bilateral tarsal tunnel. The list just keeps going and going and going, and it can all be corrected by thoughtful diagnosis followed by precision and thoughtful follow-up. It's not really that complicated, actually. Okay, so there's your thyroid gland. Now the adrenals, okay, are equally important. Okay, what are the adrenals? They're these gooey little glands that sit on top of the kidneys. Okay, are they? How many do you have? Well, you have 2. Okay, except that each one is 3 separate glands. Right? It's like the layers of an onion. Okay, so what do? You can fail. Your adrenals can fail one layer at a time, which is very, very typical. So you can have a shortage of cortisol. You end up with these fat folks that come in very typically, and they're told, oh, gee, I have high cortisol. Why? Because the commercial on TV told you? You measure it. Okay, you measure it, and inevitably it is low. Why? Because while your thyroid is burning out with autoimmune thyroid disease, initially it burns hot, and then it fails and goes cold. So, gee, I was really light when I was a kid. Yada, yada, yada. I had lots and lots of energy. And then one day, the bottom fell out, and then the weight gain started. 10 pounds a year, 10 pounds a year, 10 pounds a year. Okay, that's the poem. All right? So what happens here is a critical incident will occur. And it's usually when things break. Now, all of a sudden, the hyperthyroidism becomes hypothyroidism, but in fact, it's really the same disease. It's an autoimmune flare, a bad one. Now it turns into burnout. For most of the people listening are right now, because they didn't really care so much when they had all the energy in the world. When they were bouncing off, they could get everything done. Now that they can't roll out of bed, now's the concern. Okay, now, what do we do? Okay, so if you go ahead and run the typical gamut, okay, well, I used to have a high TSH, now it's normal, so they stopped my medicine. Well, the TSH, thyroid stimulating hormone, okay, that's what they're checking for, is not one hormone. It's actually a very large family. It's a huge molecule, okay, and some of them are stimulatory and some are actually inhibitory. Go figure that one out. Thyroid stimulating hormone can, in fact, be inhibitory. That's part of the joke, and the joke is on you, okay? So TSH ramps up initially, and then the thermostat resets. The body goes, okay, it's normal for me to have a temperature 97.6 or 96.5 or 96.1 or 95.7, and then the TSH drops. At that point, you're in the end game. Okay, that's where you're now 240 pounds, okay, and it doesn't matter what you eat or what you don't eat, you're not going anywhere, okay, and that's where many of my patients show up. They go, what do I do? What do I do? And we take it from square one, get the laboratories, and then take things one at a time. Now, first thing is that if you establish the diagnosis of autoimmune thyroid disease, or thyroid cancer for that matter, which often starts off as Hashimoto's, what you do is you shut the thyroid down. You shut down the production of thyroid binding globulin and thyroxine itself by the administration of what is now lovingly referred to as combined therapy. So what is combined therapy? Well, we used to call it just therapy. Now they call it combined therapy. I don't get it, and neither will you, but it implies that you're using both T4 and T3. So you would use your Levoxyls, your tyrosins, your Synthroid, but you'd have to add Cytomel to it, which is lyrothyronine or T3. The two together, very safe. If you give T3 by itself, it's actually very dicey. People have been known to die from it. Okay, so you just don't do that. Okay, you give them straight T4, it's a slow progressive death. You give them T3, it's faster. Or you give the two together, which can be wickedly expensive, which gets us to the other approach, which is to use a quote-unquote natural thyroid, which contains both T3 and T4 in what would be a ratio that is close to what we're supposed to get as mammals. Okay, that's the joke, okay, is that there's nothing combined about this. It's exactly what we're supposed to have. If you want to argue with your endocrinologist, argue away. It doesn't make any difference. The body needs both T3 and T4, arguably a little T1 and T2, even though we don't know what it does, okay, to work. I don't think T1 and T2 are put in your system by mistake. Doesn't mean I know what they do. But I do know what T3 and T4 do, okay? And your body needs both in order to function. T4 is inhibitory, T3 is stimulatory to the receptor. If you use just T3, you can get into some trouble. Okay, so that's why we use the two together. Combined therapy implies that the doctor really doesn't know what they're doing. If we go back to the first case, the first thyroid patient ever treated by Sir William Osler in the first part of the 20th century, it was done with thyroid extract. Okay, combined therapy. There's nothing combined about it. It worked. That you ended up with a pituitary dwarf that turned into a a thyroid dwarf, which turned into a properly looking dwarf. It's very interesting, actually, as it turns out. But the person was toast from the beginning, and that's just the way that it is. But the fact is that 35 years later, I've treated people this way, and it seems to work pretty darn well. Cost-wise, T4 by itself is actually more expensive than the branded Nature-Throid, Westroid, or Armour Thyroid for that matter. They're much, much cheaper. So on the one hand, you're getting an inferior therapy. Often they're generic, and they're still more expensive, or you buy the branded therapy, which is more consistent at a fraction of the price. So to me, it doesn't make a lot of sense to get a third-rate treatment and pay a premium to do it. It's not the way I like to go through life. All right, so now we know what the thyroid does. Now we know what the thyroid does with regards to the adrenals. We understand what combined therapy is. Okay. Now, what else do we do? Okay. Sally's thyroid is a mess. Sally's thyroid is, let's just say, toast. Okay. She's got a visible goiter. You have this little thing here called the suprasternal notch. Gee, it disappeared. Okay. That's the first thing you see in folks that are hypothyroidism. The little white areas in the males, called the lunates, they're gone. It means your metabolism is dropped. They've already ablated your uterus because you've been bleeding so much. So you don't have heavy irregular menstruation because the doctors fixed that all right. Okay, so what do? Well, we can give you the antidepressants. We can treat your cholesterol. The list keeps going. It keeps doctors in business. You gotta love it. All right. So what do? Well, the first thing we do is to start with the thyroid. Okay, and typically I administer the Nature Throid or West Throid on an empty stomach before breakfast. It has to be this way to start. Then what you do, what I do, is to ramp it up every 2 to 3 weeks, not every 6 months, which is the way the endocrine guys do it. I don't think the endocrine guys like patients very much. I enjoy seeing my patients. They come in every 2 to 4 weeks, and I adjust the medications. Go figure. Why? Because people's time is valuable. You're only given so much time on earth, and then it goes away. You then become a stone someplace. Happy days. So I would just as soon not waste a ton of time and ramp this puppy up, following temperature and following pulse as well as weight. And that's just that simple. Now, at the same time, if somebody is cortisol depleted, in spite of the fact they weigh 300 pounds, they're going to receive hydrocortisone by mouth. Because why? You have to have a proper level of cortisol in order for things to work. Simple, straightforward, easy. DHEA, same thing. Pregnenolone, same thing. Men and women, same hormones. Okay, same hormones, different ratios. So for women, an estradiol, you want to see it in the 50 to 70, 80 range. With men, you want to see it between 20 and 30. But if it's 0, nothing works. Testosterone, women, 50 to 70. Men, somewhere between 3 and 600 is usually a happy place to be. Progesterone, men and women are about the same. Somewhere between 1 and 3 makes everybody happy. Okay, so these levels are relative. They're relative to each other, they're relative to age, they're relative to gender, but they have to be measured. But what about the pancreas? You ever hear about that one? It's a cool little gland. It sits right in the curvature of the stomach and the small bowel. Okay, it kicks out something called insulin. Now, everybody knows about insulin, right? Okay, well, no, wait a second here. My doctor checks my insulin. No, they don't. They check your blood sugar, okay? Glucose, glucose, glucose. And when they don't do that, they check A1C. Oh, wonderful, okay? Useless information for the most part. Insulin level is where the action's at. So you want to keep an insulin level between 8 and 15. Most of my patients come in, their insulin level's 30, 50, 60, 90. Okay, a high insulin puts fat on you. Insulin does 2 things. It adjusts and controls blood sugar, but an elevated insulin puts fat on your stomach. So if you have an issue with a tummy that just doesn't want to do anything but grow, insulin is usually the culprit. Okay, all of these things play off against each other, so it's terribly, terribly important that you have these things checked and monitored. Okay, so what do? So you start with thyroid. What kind of diet are you on, right? Everybody wants to know, what's my favorite diet? What kind of diet should you be on? Okay, good. You can make anybody hypothyroid by what you feed them, and you can do it quickly. How do you do it? The same way the farmers in the Midwest fatten their cattle, and that's by giving them soy meal and cornmeal. Go figure that one out. Okay, it's called a Weight Watchers meal. There's no cholesterol, no fat, but you'll gain weight quickly. Why? Because the soy lecithin has 2 chemicals in it that inhibit the conversion of T4 to T3. And if you don't believe it, okay, get a hot cup of coffee, which is something that I do on a regular basis, okay, and put a non-dairy creamer in it, which is made from soy typically. Almond milk is not the same thing, but these soy powders, your temperature will drop. You measure it, you'll see it every time. Okay, you're actually, a hot cup of coffee will make you cooler. It's not a paradox, it's very chemical. It inhibits thyroid conversion. So you have to come off soy. I wrote an article 15 years ago called Death by Soy, How the American Public is Healthing Itself to Death. And I got death threats for it. Okay, why? Because they use soy in every one of those darn powders that you get at the health food store. Okay, they're garbage, absolute garbage. So what do you do diet-wise? Well, you come off soy. Okay, look through your cabinets, look through your boxes, and you'll find that every darn thing is made from soy lecithin. And you're wondering why you're fat. The second thing, how do you inhibit insulin receptors, which makes the insulin level go up? And what you do is you use high fructose corn syrup. Ooh, how interesting is that? And if you want to make cattle fat 30% in 6 weeks, that's how you do it, and that'll work for you and your kids, which is why your kids are fat. Look at the garbage you're feeding them. Okay, so that's how it's. They had asked a question that I wasn't planning to address, but I will anyway. And it's like, oh, what vitamins do you take to treat this? And the answer is There's only one vitamin that I know about that makes a difference for the adrenals, and that's B5 pantothenic acid, but almost nobody's ever deficient in it. What they are deficient in is zinc and selenium. Zinc and selenium deficiencies will lead to thyroid dysfunction, which in turn leads to adrenal dysfunction. It works in that order. So don't focus so much on the vitamins, because most of them are not healthy for you. You have to look for vitamins that are not made with soy or gluten. Terribly important. Are they available? You bet. You just have to look for them. Are they more expensive? Joke is no. They're not more expensive. Some of the most expensive vitamin preps I've seen were absolute garbage. The worst of the bunch are multi-level marketing products, because they're not interested in quality. They're interested in people getting 10%, of 2%, of 5%, of 15%. You with me? The Dukes of Hazzard mathematics. So cut soy out, cut fructose out, and things will start to improve. With regards to the vitamins and minerals, getting the zinc and selenium is very, very important. For the diabetes that often follows the adrenal dysfunction, you take chromium and vanadium. Vanadium was the very first medicine ever used to treat diabetes. Nobody's ever heard of it. Vanadium, go figure. So we use this stuff in the office on a daily basis. I get a big kick out of fixing these issues with little more than minerals and diet change. Okay, so I think I answered the needs of the discourse. Did I miss anything?
No, I think you covered everything in the topic.
Is there anybody I didn't yell at?
No, I think you got everyone there too.
Yeah, usually I try to insult everybody equally, and so yeah, but I typically pack a house. So why don't you go ahead with your questions and let me know.
Absolutely. So we've received some questions from fans of the Nature Thyroid and WP Thyroid Facebook pages, and if you're not following them yet, please like them and follow them. So the first question is, Dr. Klein, I've taken a few makeshift tests via the net to see where I stand. Honestly, I tend to have symptoms reflecting both hyper and hypothyroidism. Would this combined therapy treatment work?
Okay, and the answer is, I can't even imagine why you would be getting random tests over the internet. Okay, that usually implies salivary hormone levels, which are absolutely useless. Now, I've got 5 board certifications. I'm a CLIA licensed, highly complex lab director. I know something about laboratory diagnosis. I was an analytical chemist before I was a doctor. I know something about the analytical process. Salivary hormones are not predictive of anything other than salivary amylase. So if you think you have a salivary amylase issue, it makes sense. Otherwise, you can't do random blood work over the internet. Okay, so the better answer is if you're asking the wrong question, you're very, very likely to get the wrong answer. So my advice would be to get this thing tested properly. How do you do this? T3, not free T3, but total T3, total T4, TSH, TPA, and ATG. All of these things are drawn by way of the serum. That's called blood. If you didn't get this thing by way of the bloodstream, you have no data whatsoever. Now, you say, well, does that sound a little harsh? The answer is, it's reality. The powers that be have looked at salivary assays, which would be wonderful, okay, if they worked, but they found they were non-reproducible. Well, being the kind of guy that I am, I went ahead and tested it. So I took 10 patients, took split samples on 10 people, as well as blood, and then looked at the results. Now, these are identical people with 2 separate samples being sent to the same, and ended up with results that were absolutely non-correlative. Okay, they made absolutely no sense. Well, why is this? Well, for starters, the salivary gland is a very minor player in the entire process. I mean, why not use earwax, tears, or urine, right? Well, I don't know. I mean, it makes no sense there either. And then, cleverly, you stick it in a box. It sits in the back of a UPS truck at 130 degrees, and in Phoenix it's probably hotter, okay? And then whatever's in this just is absolute garbage. If you think that the value of these tests is any good, why don't you mail yourself some cottage cheese, and at the end of the process, eat it, okay? And if you don't get sick, you won't understand what I'm talking about. These biological systems are extraordinarily sensitive to temperature and time. So in my office, we draw the blood and run it right there in the office. Okay, within 1 hour, we have all the assays we need. We're the only ones actually in the world that's able to do this at this time. That'll change eventually. Okay, but it's nice being first. I like that. Makes me happy.
Who doesn't?
Okay. Yeah, question number 2.
Question number 2 is, I was diagnosed with thyroid cancer 16 years ago. Small positive nodules pop up every 3 years and treated via alcohol ablation. Is Natrethroid safe to use for suppression therapy?
And the answer would be that's precisely how I do it. Okay, I want to shut the TSH down to 0. Okay, and then what you do is you adjust the dosage based upon temperature, pulse. If you can do that, you're good to go. So is it safe? Yeah, it's very, very safe, and in fact, it's the way that I do it. I do my own thyroid ultrasounds in the office. Okay, so it's which is kind of cute. I kind of enjoy not having to ask anybody else to do it. But the answer is yes. And now, what else can you do? Now, let's say this has not been published yet, mainly because I'm too lazy. But somebody comes in with Hashimoto's thyroiditis, right? Inflammation of the thyroid. And after one of my radio shows, so she drove over to the office, and she was very, very hoarse, could hardly speak. And so what had happened was she had thyroiditis, heard my show. I don't know which show she heard. It doesn't really matter. And then, so I told her, I said, hey, look, first thing you want to do is settle the inflammation down. So I tried something I hadn't done before, which was I put a topical anti-inflammatory directly on the thyroid, settled it down within 2 or 3 or 4 minutes, and her voice returned. Okay, the medication I use is called Pensade, which is a 1.5% diclofenac. It's Voltaren in DMSO. So it went right through, settled down. She's very, very happy. So one of the things that I attend to now, having learned my lesson, is that I use anti-inflammatories for my patients with thyroiditis. But to this person that has the thyroid cancer, you better check your TPA and ATGs, because more than likely that was the precedent disease state prior to the development of the papillary carcinoma, which is probably what this was. Okay, that's how you do it. Lastly, on that score, and if that person's listening, and I hope they are, there's a medication, it's a prescription called Metformin. You can get it for free at Publix, which is a local grocery store here. It's probably it'll be a chain near you, and they actually give away Metformin for free. It's used to treat diabetes, but if you do a little literature search on it, you'll find that Metformin has been shown to reduce the incidence of thyroid cancer as well as breast, colon, and melanoma for that matter. And the stuff is cheap. So I'm currently taking Metformin, not because I'm diabetic, which is what it's usually used for, but because it reduces your risk of cancer, and I'm promoting that very, very heavily on air. Next question.
Excellent. So the next question is, can the saliva cortisol test be wrong? Mine showed normal, but I have felt anything but normal.
Yeah, the answer is listen to the first 20 minutes of what we just discussed. The salivary hormones are for rank amateurs and wannabes. The only people that really do these with any regularity are compounding pharmacists, many of whom are friends of mine, okay, because I lecture to them also. But compounding pharmacists, chiropractors, and people that can't or won't draw blood in their office. Okay, it makes no sense. A salivary cortisol, okay, we charge, I think, $30 to do it. I mean, big deal. That's a blood study. You get the answer in an hour. Okay, you go to Quest or LabCorp, it's $30. Okay, why do you want to do a salivary study if you can get the real deal much quicker? So the answer is, of course, it's nonsense. Now, that being said, okay, you're looking at a cortisol level in saliva. Now, have you ever had a dry mouth? The answer is, of course you've had a dry mouth. Medications make your saliva become more concentrated, the weather changes, and dehydration. So you can change salivary concentrations of everything with an enormous list of medications, foods, okay, as well as environmental conditions. Doing saliva testing is absolutely one of the most ridiculous things anybody can do. It's misleading at very best. Okay, I would rather have no information than a saliva test because it's always misleading. It wastes my time. If somebody comes and, oh, well, my chiropractor told me that my cortisol was high because of my saliva. They always say that. That is what they always say. Well, guess what? You know, today I ran 12 or 13 cortisol levels, and they were all, not all low, I think we had 3 normals. Okay? Cortisol is almost always low. And I can tell you it's not concentrating in the saliva. Next.
Okay, actually, thank you for that answer. That actually wraps it up for our questions.
Cool.
So again, thank you for your responses. And at this moment, Dr. Klein, I'd like to invite you to say a little bit about your practice for those out there who may be looking for a new doctor.
Okay, you know, okay, what I do what's called functional medicine. Okay, I've been doing it a lot longer than there was a functional medicine. What this is, it's like the jolly land of being a general practitioner. Okay, even with a bunch of specialty boards. I'm called a super specialist, actually, but I consider myself to be a GP. What this means is I use those medications, those prescriptions, those OTC, over-the-counters, those modalities, methods, and whatever that are necessary to get the job done. Okay, the difference between a nutraceutical and a poison is rate, route, and amount of administration. So people come and go, oh, I want to treat this naturally. Say, good for you. Okay, I'm going to treat it the way I know I need to do it. Nature-Throid is natural, but it's a prescription item. You can't just go out and buy it. Westhroid is a natural item. You can't just go out and buy it. But they're very, very safe. You can go out and buy aspirin, which by its nature is not safe. Okay, Tylenol kills more people every year than any other drug. Number 2 would be alcohol. Number 3 would be tobacco. They're all over the counter. Okay, so it doesn't matter whether something is prescription or quote-unquote natural. You can do damage with it or you can heal with it. With the possible exception of mercury and lead, most everything else is both a poison and a nutrient. Okay, so what do? I treat what I need to treat. I've been doing this a very, very long time. I get patients from all over the world. I don't know what else to say. But okay, you can read about me should you choose to at www.suffernomore.com or stagesoflife.net. We have a radio show which is on wdbo.com/Ask the Experts. We're on every Sunday from 3 to 5 p.m. Eastern Time.
Thank you, Dr. Klein. And you can also stay up to date with Dr. Klein and Stages of Life Medical Institute by liking their Facebook page, facebook.com/Stages of Life Medical Institute. So at this time, I would like to thank you again, Dr. Klein, for joining us, and thank our viewers who tuned in. And again, for information, support, please be sure to like the Nature-Throid and WP Thyroid Facebook pages, as well as the Stages of Life Medical Institute Facebook page, and stay tuned for our next Hypothyroid Hangout. Again, thank you, Dr. Klein, so much for joining us tonight.
It is my pleasure.
Good night.
Good night.